The title of my talk is Approach to the Patient with Cirrhosis, a primer for primary care providers. I hope I can provide you with some practical information that you can use as you see this type of patient in your clinic. I have no financial disclosures relating to the content of this talk. The development of cirrhosis is considered the end stage of most chronic liver diseases and represents a very important clinical landmark for prognostic and therapeutic purposes. Decompensated cirrhosis is associated with poor life expectancy, and chronic liver disease represents the 10 to 12th leading cause of death in the United States. Thus, affirming the diagnosis of cirrhosis is very important as a first step to the future care of your patients. In order to determine the likelihood that your patient has cirrhosis, you should consider the following. Do they have underlying chronic liver disease? Does their physical exam support the diagnosis of cirrhosis? Does the laboratory and imaging studies confirm this? Is a liver biopsy necessary? The most common cause for chronic liver disease, particularly in the Veterans Administration, include hepatitis C, non-alcoholic fatty liver disease, and alcoholic liver disease. Determining whether these diseases are present will require directed testing and clinical assessment. Although less common, hemochromatosis and hepatitis B are equally important to rule out, since making any of these diagnoses can result in treatment which may actually reverse some of the liver fibrosis and prevent decompensation of your patient's liver disease. The physical exam findings are very helpful in supporting a diagnosis of cirrhosis, including ascites and spider angioma. But it should be noted that physical findings generally are not present until patients have decompensated cirrhosis, at which time it may be too late to intervene with preventive treatments. Endoscopic exams showing gastroesophageal varices also support a diagnosis of cirrhosis, but often these are performed both to confirm cirrhosis as well as to prevent the first variceal bleed in a patient with suspected cirrhosis. In addition to these physical findings, laboratory findings, particularly those that measure liver synthetic functions such as albumin and prothrombin, are very important to confirm the diagnosis of cirrhosis. The presence of thrombocytopenia is also very suggestive of cirrhosis, particularly in patients with hepatitis C. Imaging studies showing cirrhotic morphology or the presence of varices can often provide significant support for the diagnosis of cirrhosis. A liver biopsy is the gold standard for confirming the presence of cirrhosis, but it is usually not necessary to make the diagnosis if there is enough clinical evidence. Because a liver biopsy is associated with the risk of complications in up to 84% for pain and 0.1 to 2% risk of bleeding, as well as actually a 0.1% risk of death, the physician to perform a liver biopsy needs to weigh these risk versus benefit. Once a diagnosis of cirrhosis is made, the next step is to assess the liver function. One of the first differentiation is to determine whether your patient is compensated or decompensated. This refers to the development of complications of cirrhosis, including ascites, variceal bleed, and hepatic encephalopathy. As you can see on the graph, the development of decompensation, as defined by the presence of ascites, jaundice, upper GI bleed, or hepatic encephalopathy at the time of presentation, was associated with a significantly worse 5-year survival compared to patients who were compensated cirrhotics. It is generally recommended that if your patient is decompensated from their cirrhosis, consideration for referral to liver transplantation should be made. Another method to predict prognosis in cirrhosis is by calculating the Childs-Turcotte-Pugh score. The Childs-Turcotte-Pugh score is calculated by considering 5 factors: encephalopathy, ascites, bilirubin, albumin, and the prothrombin time, or INR. Based on the presence or absence of these factors and the relative numbers, they are assigned 1 to 3 points, and the addition of these numbers result in a score which classifies them into Childs A, 5 to 6 points, Childs B, 7 to 9 points. For patients with greater than 10 points, the patient has Childs C cirrhosis. 1-year survival in this 1987 citation was noted to be 100% if the patient had Childs A cirrhosis, but only 45% if the patient had Childs C cirrhosis. This illustrates a significant spectrum of disease and prognosis even after a diagnosis of cirrhosis is made. Another way to calculate prognosis is to calculate the MELD score, the Model for End-Stage Liver Disease score. The MELD score uses only objective findings and encompasses a greater range of numbers than the Childs-Turcotte-Pugh score, so this has been adopted by the United Organ Sharing Network, UNOS, as a way to predict which patients with cirrhosis are the sickest and requires the next liver transplant. The MELD score is derived from an equation which includes bilirubin, INR, and creatinine. The creatinine is quite weighted in this equation, supporting the concept that renal function is actually very predictive of outcome in cirrhosis. You can calculate the MELD score by using an equation which is provided by UNOS in the website attached, or by searching the internet with the words MELD calculator. As you can see on the graph, the 3-month survival can be predicted by the MELD score, with 100% survival at MELD scores less than 9, but less than 20% if the MELD score is greater than 40. This is very helpful to assess how sick your patient with cirrhosis is. In addition to liver transplantation, which can be life-saving for those patients at the end stages of cirrhosis, it is important to make the diagnosis and care for your patients prior to them getting to this point. If you can address the underlying liver disease prior to them reaching this end stage, you may be able to impact on their survival and quality of life. In the past, there was a general perception that cirrhosis represented the end stage of liver disease and thus was considered not reversible. However, as we derive a better understanding of the fibrosis process, we now realize that this is a very dynamic process, which involves both laying down scars and removing scars. So if you are able to find the offending agent early in cirrhosis, there is hope that you can stall, if not improve, the progression of disease. There is likely a point of no return for some patients where the damage is too extensive to improve, but for many, if you can remove the offending agent, the patient can lead a much longer and productive life in the face of cirrhosis. Thus, it is important to consider intervening, if possible, with underlying diseases such as hepatitis C. Compensated cirrhotics can actually be considered for antiviral treatment if pancytopenia is not significant. Removal of alcohol can result in significant improvement in some patients, particularly in the subset of patients who have alcoholic hepatitis. Treatment of hepatitis B is recommended for cirrhotic patients with significant viremia. Treatment of autoimmune hepatitis in a patient with cirrhosis can significantly improve the patient's outcome. With regards to NAFLD and primary biliary cirrhosis, treatment is much more effective if instituted early in their disease, but nevertheless, cirrhotic patients should still be considered for treatment if possible. In addition to treating the underlying liver disease, addressing the manifestations which can occur as a result of cirrhosis is important. Gastroesophageal varices are present in approximately 50% of patients with cirrhosis, and the incidence increases with the severity of liver disease, such that 40% of patients with child A cirrhosis have varices, but this increases to 85% in patients with child C cirrhosis. Variceal hemorrhage can be devastating and occurs with a yearly rate of 5 to 15% per year. There is a very high 20% 6-week mortality from variceal bleeding, making prevention of the first bleed and recurrent bleeding very important. In order to prevent the first bleed, you have to assess whether varices are present. Therefore, a screening endoscopy (EGD) is recommended at the time of diagnosis of cirrhosis. If medium or large varices are found, nonspecific beta blockers such as propranolol and nadolol are recommended. Propranolol, the formulary choice in the VA, should be started at a low dose and titrated to a pulse reduction of 25% of baseline with attention to blood pressure, as cirrhotic patients may have baseline hypotension. It is important to note that as your patient develops progressive liver disease, their previous hypertension may improve, so adjustment of prior hypertensive meds may be needed to accommodate this nonspecific beta blocker. If the patient has already bled from esophageal varices, it is important to recognize that endoscopic eradication should be initiated. Please note that endoscopic eradication usually takes more than one session and should be carried within weeks of each other until the varices are gone. This is particularly important to remember if your patient started their endoscopic eradication regimen at a facility outside of the VA and follow-up endoscopic procedure is not scheduled. It is important that the patients have their varices eradicate within weeks of the initial bleed, as they are at highest risk to rebleed early on. Once the eradication is completed, then endoscopic surveillance periods may be lengthened. The patient should also be placed on a nonspecific beta blocker to prevent rebleeding. Hepatocellular carcinoma, a dreaded complication of cirrhosis, has also been rising. Hepatocellular carcinoma is now the 5th most common cancer worldwide and the 3rd most common cause of cancer mortality. Hepatocellular carcinoma accounts for 85 to 90% of primary liver cancers. The age-adjusted incidence of hepatocellular carcinoma has increased at least twofold between the periods of 1975 to 1998, and this has continued to rise steadily, particularly in the VA, where there is a high incidence of hepatitis C and a growing number of patients with non-alcoholic fatty liver disease. Overall, the worldwide incidence of hepatocellular carcinoma is greater in male than female with a 2-to-1 ratio. The presence of cirrhosis greatly increases the risk of hepatocellular carcinoma. In a patient with hepatitis C cirrhosis, the incidence is very high with a rate of 3 to 5% per year. Because of the increased risk of hepatocellular carcinoma in cirrhotics, surveillance is recommended. The AASLD guidelines recommend the use of ultrasound every 6 months to screen for hepatocellular carcinoma. Early detection is the only method which will allow for reasonable outcome. If new nodules are found, particularly those larger than 1 centimeter, further investigation is recommended with either a 4-phase multi-detector CT scan or dynamic contrast-enhanced MRI. If the appearance is typical of hepatocellular carcinoma, that is, hypervascular in the arterial phase with washout in the portal venous phase or delayed phase, the lesion should be treated as hepatocellular carcinoma. Most diagnoses of hepatocellular carcinoma can be made radiologically, and the biopsy of the lesion is often not needed. If the characteristics of the lesions are indeterminate for hepatocellular carcinoma, a second contrast-enhanced study is usually recommended prior to recommendation for biopsy. The rationale for this is that the lesions are often small and thus the miss rate can be quite high. In addition, there is concern for tracking of cancer cells with biopsy, and thus biopsy should only be recommended if the diagnosis cannot be made on a radiological basis. Ascites is another complication of cirrhosis which is associated with significant morbidity and mortality. I will only focus about a few key points regarding ascites as this is a topic for an entire other talk. For new-onset ascites, a diagnostic paracentesis with measurement of the SAG, serum to ascites albumin ratio, and cell count is important to confirm that the cause of the ascites is indeed due to cirrhosis, and also to rule out spontaneous bacterial peritonitis, which can have devastating consequences in the cirrhotic patient. First-line treatment of ascites includes sodium restriction, which is often undervalued by the patient but is very important. We generally recommend a 2-gram sodium restriction per day as this is within reasonable range for compliance, but still contains very little sodium. Diuretic therapy is recommended with a combination of spironolactone and furosemide with a ratio of 100 milligrams to 40 milligrams, which can be titrated to a maximum dose of generally 400 milligrams and 160 milligrams respectively. Careful attention to electrolyte balance and renal function is important with the up titration. It is important to remember that patients who have developed spontaneous bacterial peritonitis previously have very poor prognosis. They will likely require the care of a liver specialist and referral to liver clinic is recommended. However, remember after they have had the episode of spontaneous bacterial peritonitis, patients should be on antibiotics to prevent future episodes. The best studied is norfloxacin to prolong survival, but as this is non-formulary in the VA, a reasonable alternative includes daily dosing of Bactrim or ciprofloxacin. Similar to ascites, hepatic encephalopathy is a significant complication of cirrhosis which is associated with morbidity and mortality. A few key points to remember. Hepatic encephalopathy is a clinical diagnosis. Serum venous ammonia levels are very unreliable and have little role in the diagnosis or management of hepatic encephalopathy. Lactulose is the first-line treatment and should be titrated to 2 to 3 bowel movements per day. Rifaximin is a very good treatment for hepatic encephalopathy, but given the cost, it should be used if there is failure or intolerance of lactulose. Protein restriction should not be broadly instituted given that cirrhotic patients have significant issues with nutrition, which impact their mortality. Only a small minority of patients with hepatic encephalopathy actually benefit from protein restriction. General maintenance care in cirrhosis includes vaccination for hepatitis A and B, which is recommended in patients with chronic liver disease. The vaccination for pneumococcus and influenza is also recommended, since viral infection in this population is associated with worse prognosis. Although there is no definitive data to support vitamin D supplementation and osteoporosis screening in cirrhotics, it should be noted that these are very prevalent in this population. Male cirrhotics have a similar risk for osteoporosis as postmenopausal women. There are many myths with regard to medications in cirrhosis, as many drugs are metabolized by the liver. In general, it is wise to avoid nonsteroidals as they increase the risk of bleeding and can have nephrotoxic effects, devastating in a cirrhotic patient. Nephrotoxins, particularly aminoglycosides, should be avoided in cirrhotics as they are particularly prone to renal failure with these agents. Benzodiazepines, narcotics, sleeping medications, should be avoided in cirrhotics, as this will often trigger or worsen hepatic encephalopathy. Acetaminophen can be safely used if limited to less than 2 grams per day for pain, and given the scarcity of other alternatives for pain medication, may actually be preferred. With progress of liver disease, patients' cholesterol often decreases, but if the patient meets guidelines for treatment of hyperlipidemia, it is important to note that statins are not contraindicated in cirrhosis. In summary, cirrhosis is the end stage of many liver disease. However, if diagnosed early, management and treatment can be proactive. Determining the underlying cause of cirrhosis can lead to important treatment options which can stall the progression of disease and improve outcome. Evidence of decompensated cirrhosis should trigger a consideration for liver transplantation evaluation. Surveillance for esophageal varices and prevention of the first bleed or recurrent bleeding is important. The incidence of hepatocellular carcinoma is rapidly rising, and surveillance to capture early disease is recommended. Thank you for your attention.